Well, good morning or good afternoon to everyone who's with us today for our Innovation Awards program presentation to highlight the Docs for Tots Well Moms, Well Tots Maternal Depression program. We're so thrilled to have Melissa Passarelli with us today. We'll introduce her in just a moment, but before we do, want to give a shout out and a big thank you to the Zoma Foundation who made this program available, the Innovation Award program. The goal of this program, the Innovation Awards program, is to not only recognize innovative programs that are making a difference with outcomes that are evidence-based, but also to lift up those models for all of you who are listening now to adopt. And again, the goal is really to proliferate these outstanding programs. So congratulations, Melissa, to you and your team at Docs for Tots for receiving the honorable mention in Innovative Community Solutions category in the Innovation Awards program. So welcome, Melissa. I'm going to go ahead and move to the next slide so folks who are watching the webinar can see both of us. My name is Joy Burkhardt, and I'm the Executive Director of 2020 Mom, and I now have the great pleasure of introducing Melissa.
Hi, everyone. Thank you for having me.
Great. Thanks, Melissa. Melissa is the Director of Programs at Docs for Tots, where she oversees various initiatives, including the Maternal Depression Initiative, which you're going to hear about today. We'll also, Melissa, have a chance to ask you a little bit more about your adverse childhood experiences work later on today. Melissa earned her MA, her Master's of the Arts program degree, in International Disaster Psychology from the University of Denver, and also trained as a trauma therapist in disaster and a disaster responder, working with refugees, homeless women, and children, including survivors of sexual assault. And she's done that work both here in the U.S. and internationally. And prior to her current work at Docs for Tots, she also received her degree in psychology and public policy from the George Washington University, which we're all very interested in too, Melissa, and also worked for various nonprofits, including Fiverr's Children's Foundation and First Book. So we're so thrilled that you're with us today, Melissa. Thank you so much.
Yes, I'm excited to talk about this program.
Great. I mean, and what an extraordinary background you have. And if you don't mind, I'd like to just pause on your fantastic educational background and experiences, both here in the U.S. and internationally. And do you want to touch on your experiences and sort of how they led you to Docs for Tots? And then we'll talk a little bit about who is Docs for Tots and where you're based, et cetera. But anything that you want to highlight about your past experiences and sort of how it culminated to bring you to Docs for Tots?
Sure. It felt like a winding road at the time, but now looking back at it, it ended up being a very clear path because all I ever knew that I wanted to do was make a difference. And so at first I thought that would be via public policy, which is why I went to DC to study that. In the course of working there, I did kind of the lobbying side, interning at different lobbying firms and with congressmen, and wasn't necessarily my bag. I thought it was interesting, but I wanted to see things from another perspective. So then I started working with nonprofits that were headquartered in Washington, D.C., like First Book, which is an organization that provides new books to low-income children around the country. I really loved that kind of social innovation and the way that those organizations worked. And at that time, I was also studying psychology and kind of working locally in DC with children that went to school there and kind of seeing a lot of children who were facing a lot of struggles and their families were facing a lot of struggles, and how that kind of affected everything that they were experiencing at school and at home. And that kind of other things happened, but I ended up receiving my master's in international disaster psychology, which sounds really specific, but in essence is looking at cross-cultural implications of trauma, both on an individual level and a population level. So not only was I trained as a trauma therapist and how to address manifestations of trauma with individuals and groups, but we were also taught public health approaches to incorporating mental health and kind of like mass trauma events or trauma-focused care into every aspect of society, whether that be governmental policy, healthcare, the education system. And we were taught like a very intensive cross-cultural approach to that, which has been very beneficial. So even though I don't actually work abroad, I now work at Docs for Tots. And the story of how I got there is also interesting, but it actually comes up a lot because we work primarily in the region of downstate New York, so Long Island area, and there is growing immigrant population, and currently the local systems are just not designed to meet the needs of those populations. So I find it really fascinating to work across different systems, looking at how we can change our approach to, adequately address all families' needs.
Great. Well, thank you so much for your work. And there is so much intersection, it seems like. And, some of our listeners, I know, have public health backgrounds or work for nonprofits and community-based organizations. So just to hear how it all has come together for you, I think is quite interesting. And of course, 2020 Mom is very engaged in policy work, and you've done that too. So just a great set of skills and experiences all kind of coming together. Well, let's talk just a little bit about Docs for Tots. Tell us about the nonprofit organization and your mission, etc.
Absolutely. Docs for Tots is just as it sounds. It's a pediatrician-led nonprofit that focuses on improving outcomes for our youngest children. So we look at that as prenatally through age 5, because we know that the first years of life have a lasting impact, not only on the individual, but kind of society at large. And rather than working directly with children and families, we work with the professionals that regularly interact with children and families, such as physicians, child care providers, other social service providers, to help them translate research into practice. So kind of implementing best practices to address these issues. And we also do a lot of cross-systems work. So bringing together doctors, policymakers, early childhood educators, families, in order to approach these issues together.
It's great. And, it's a fascinating model to me because I haven't heard about a nonprofit, pediatrician-led nonprofit that's specifically serving communities by leaning on pediatricians. And so I don't know if you know of other nonprofits across the U.S. that look similar, but it just feels to me like you're in a very innovative model. And though I think you've been around for quite a while in New York as well. Is that right?
Docs for Tots has technically been in existence for 15 years, but in its current iteration, it's been in New York for about the past 5 years. It had started kind of with a different mindset in DC as more of a physician network or advocacy organization, and it was brought up to New York by our current executive director, Dr. Liz Isaacson, and another physician, Dr. Dina Leeser, a few years ago. So we've kind of since then been focusing a lot more on practice change in pediatric offices, as well as kind of more focused cross-systems work, specifically in New York.
Perfect. That's really helpful. Thank you. Well, let's talk a little bit more about, you hit on the region of New York that you're in. Is there anything more that you want to share about Nassau County and the population? And then let's talk a little bit about what are FQHCs as well.
Absolutely. So we do focus primarily on New York State, but the region that we really do most of our work in is Long Island, which is a shock to most people across the country, because when people think of Long Island, they think of the Hamptons and the Great Gatsby and just general images of wealth. that some of that is true. However, there are growing pockets of need, particularly in Nassau County. So for anyone who's unfamiliar, Long Island we've got some of the boroughs of New York City on the physical island. So when we talk about Long Island, we're talking about Nassau County, which is just right of the city, and then Suffolk County, which stretches all the way out to the Hamptons. And both counties have growing pockets of need, but in particular, Nassau County is deemed one of the most disparate counties in the country for just, how, like, the spread of wealth. And what happens when you're looking at statistics is that those wealthier families and families that, are able to afford more and better healthcare, for example, their statistics kind of mask the needs of these other growing communities of need. Nassau County put out a health report a few years ago where they actually pulled out selected communities from Nassau, and they compared the county as a whole to those selected communities, and you can see the disparities right there. So federally qualified health centers are health centers that exist across the country that receive federal funding to serve Medicaid patients. So these are health centers that are reaching the families that we most want to reach, because everyone who goes there is on Medicaid or is uninsured. So when we knew that we wanted to address maternal depression as a pediatric issue, because Dr. Tots is primarily looking at outcomes for young children, and we know that maternal well-being is directly linked to developmental outcomes. So we wanted to look at this as a pediatric issue, and we knew that the federally qualified health centers, particularly in Nassau County, were the best way to reach the population that we wanted to reach most. And the reason that interventions via health centers are so effective is that, especially for young children, there's really no one place to find the child before they get to school. However, 92% of children will see a primary care physician before they enter school. So, at least once, if we can get that doctor's visit to be as comprehensive as possible in addressing all of these issues, that is the only near universal access point we have to young children.
Great, thank you. Thank you very much. Let's move on to, let's talk a little bit about the champion behind this work. You clearly are a champion and sort of administering the program, but how did it first come to be? How was it raised as an issue, maternal depression? What were you seeing? And was there one champion at Docs for Tots that really knew it was time to do more?
I think it's a combination of a lot of things. I could actually back up and talk a bit about a previous program that Dr. Tots had that kind of led to this. So back in 2014, Docs for Tots had a project with the goal of implementing standardized developmental screening during pediatric visits, with the ultimate goal of identifying developmental delays in young children earlier and referring to services that could help earlier. And we did this by working with federally qualified health centers located in Nassau County, because we know that, doctors should be screening, but there's a lot of barriers to them doing so. And federally qualified health centers, typically are kind of more overworked and underpaid than other sites, and they're reaching the families that we want to reach. And so we provided intensive technical assistance at every level of staff, all across what we called like the visit workflow, in order to integrate screening in such a way that when we left, it would still be sustainable. So that meant, working with the front desk to hand out a developmental screen for the families to complete in the waiting room, and then the medical assistants, when they're, bring families in to do height and weight, their role was to collect the screen and put it into the computer system, the electronic medical record. And then when the physician came in, they would look at the screening results in the medical record and review them with the family, and then make a referral as needed. So that went really well. And in fact, 6 months after we had completely finished the project, we had them run a report, and we found that all sites were still screening 95% of the time. And we said, this is great. This model of doing things is working, and we know that in this area, at least, we're not doing a good enough job of identifying maternal depression, even though we know it exists. And at the same time, there were a lot more maternal depression, and kind of addressing that as a major issue, especially as a major issue in early childhood, was gaining national attention and state level attention. There were a lot of policies and suggestions that came down both from state and national experts, but also from physician boards, saying that maternal depression should be screened and should be part of the pediatric visit. So we kind of built off that momentum and said, why don't we go back into the sites that we had such success with before and layer in maternal depression screening as another thing that they're able to offer their families.
That's great. And it's helpful to know, like, what was the sort of the impetus to do more, and what I'm hearing, multiple things, as you've said, but I love that you point out the role of both, the American Academy of Pediatrics, who's really the leader in acknowledging the importance of detecting and treating maternal depression and maternal mental health disorders, right, above all other trade associations. So just bravo and a shout out, right, to the American Academy of Pediatrics and really understanding the implications to children as well. But also you hit on public policy, and just to acknowledge that New York really has been a leader in this space, and it's still addressing, right, both at a city level in New York City and also at a state level, still addressing maternal depression. And that's because of some of the great advocates that individuals that have been leading this work in New York for quite some time. So just great to hear how that can also trickle down and impact and inspire these kinds of great programs and how important it is. Great. So let's move on to actually talk a little bit more. And you hit on some of the screening program components, but tell us a little bit more on this notion of technical assistance is really sort of the heartbeat of your program. So tell us more about your program.
Yes. I think that it's funny, even the practices will sometimes underestimate the necessity of that intensive technical assistance. But let's just think of it this way. We can have as many policies or guidelines out there as we want. And as you said, you applauded the American Academy of Pediatrics. I do as well. It's a lot easier to say this should be a standard part of pediatric care than it is to actually implement that. And there are so many little things that get in the way that sometimes even, health providers aren't aware of. I think that the more and more we work with different healthcare providers, the more we realize that everyone has their role to play and is familiar with their role, and sometimes doesn't necessarily see, because they're kind of busy doing their thing, other things that other roles, have as part of this process and what can get caught up. So our big thing is we recognize the little barriers that get in the way of a lasting implementation of something like maternal depression screening, and our role is to work with each part of the clinic to overcome that so that it just becomes a sustainable part of their work. I will say that before we started doing this intensive technical assistance, we did an extensive literature review, both at the time around developmental screening, around practice change, and around quality improvement. And I came in not as a physician, but looking at all of this, and I was like, wow, all of the kind of screening implementation toolkits, regardless of what type of screen, but any kind of implementation toolkit that's out there really is from a physician perspective and focuses on the physician role, which is wonderful. But my experience is that there's so many other aspects to a visit that are being undervalued, such as what's happening kind of at the front desk and in the waiting room, and what's happening with whoever comes in and does your height and weight before the doctor sees you. So whether that be a medical assistant or a nurse, that's a huge part of the process, and yet those weren't being really identified as a meaningful part of this practice change in the literature. So the way that we approached it was we, and this is kind of all up on our screening toolkit on our website, which is up on the slide. The screening toolkit is based on our developmental screening project. However, it's really the steps that we took that we think that practices can kind of take on their own to implement screening, regardless of what type of screening that is. But there was a focus on making sure that the entire team was on board at every step of the way. So we would start with sitting down with the team leadership, and we wanted, and typically that means a representative as like the lead physician at a site, whoever is the office manager, and then if there's a nurse manager, we'd have them as well. And we would kind of go over why we think that this should be, a standard part of their practice, what they would get out of it, and then we would learn from them, what does your visit look like? So literally from the time a patient walks in to when they leave, what does that process look like for them and for your staff? Where are the points of opportunity here? And where are any, concerns that you may have that we can help address? And based on that conversation, we'd make a plan. We would then present that plan to the entire staff. This was very important. We called it staff buy-in. And we said, everyone has a staff meeting at least once a month. We need half an hour at that staff meeting. We need to go over why we're doing this. So in this case, why should any of the staff members care about maternal depression, and why, how does it affect kind of their role, and what part can they play in identifying and properly referring moms to services that can help them. Then we would kind of go over what the process will look like. And then after that, we would do training, so it's kind of on an individual and small group level. So for example, we may go and talk to all of the medical assistants about what their role would be, but then we check in individually with each medical assistant to make sure that they got it. We would prepare the exam rooms and the waiting room, or wherever, with all of the materials that were needed, which includes screens, educational materials to hand out to parents, referral packets, things like that. So we would kind of go through and do that. We'd put little reminders in each of the exam rooms for hey, is a family here, in this case, for a well child visit with a child between the ages of 0 and 1 year? If so, we want to provide a screen. So make sure that you're doing that. And then once all of that is up and running, there's this that's kind of, the job's not done. It's kind of just starting. Everyone thinks it's going to be perfect and great, and okay, now we're going to do it, which is typically true for the first month. But we would sit down every month and run a report with the staff, and then kind of look at what happened. If there were things missed, what can we identify about why that was missed? How can we address that? What changes can we make? And then let's go back to the drawing board and try again for next month. And typically, the first month would be an amazing success rate. 95% of the families that should have been screened were screened. Wonderful. And then, you come back a month later and 60% of the families that should have been screened were screened. So that's really where that intensive ongoing work comes in, and where that quality improvement approach comes into play, to make sure that we are addressing all those little issues that come up that lower that screening rate. And as it says on this slide, I did require a full-time practice coach. We were able to kind of concurrently work. We would kind of start working with one site, get that up and running, then start a next site. So at one point we were concurrently working with 5 sites, but the length of time that we were working with each of those sites was months at a time. So it does take a lot of intensive on-the-ground work, but it does end up having good results.
Great. That's really helpful. Can you expand? I love that conversation, just briefly, about the time that you spent with each FQHC. Can you touch on that again? How long did it take to start and then really see X number of months of success where you felt like you could walk away and maybe be just a remote resource?
So we say at least kind of 4 months of intensive work, and then we kind of wean it down. But intensive means after that initial month of all of the trainings being done, making sure the exam rooms are full. We stop in at least twice a week. Typically they'll have what they call a huddle. So at the beginning of the day, they have all the staff come together to kind of run through what's going on for the day. We'd show up, be like, hey, just a reminder, the screening is happening, things like that. Popping in regularly is also important to speak kind of off the cuff with staff, because more often than not, barriers to making the screening a successful long-term thing don't show up in the reports. They show up in the staff experience and kind of informal feedback that we would get. So an example is there was one site that was screening regularly at very high rates, and I had gone and kind of checked in and was speaking with one of the medical assistants, and we were just, talking about the process and everything, and he's like, well, yeah, but it takes a lot of time. And I said, what do you mean? He's like, oh, it takes me about 15 minutes to do this developmental screen with the family in there, which is absolutely not what we wanted, and that's not sustainable at all. But that didn't show up in the report. The report said, hey, they're screened 95% of the time, but it didn't tell me, hey, it's taking so long to do this that this eventually is going to become a barrier that is not going to be lasting. And we realized that the issue was language and literacy, and that the staff, they had a large Spanish-speaking population coming to the clinic that also had literacy concerns, and the staff, not all of them spoke Spanish, so they couldn't necessarily read the screen aloud, and so it was just taking a lot of time. They had to use a language line, etc. And so that kind of on the ground, being there at least several days a week to pop in, speak to people, check in is really crucial, and that lasts several months and then kind of wanes to a point where maybe we're checking in once a month just to make sure that they did a monthly evaluation to see how that's going.
Got it. That's great. Well, do you mind if we stay on that point for just a minute about language barriers? Since there is, that can be a challenge, I think, for many communities. How did you eventually overcome that 15-minute sort of assessment issue? Did you have certain staff do the assessments, or how did that end up working?
So that was for our developmental screen, which was a bit longer. What we ended up doing was creating audio files. So we had a Spanish audio version for each age range of the screen that they could play for the family to help complete with it. With the maternal depression screen, I didn't really get into the details yet of how we did that, but we started with a PHQ-2, so those 2 questions given out at the front desk. And the idea was, if we give it out at the front desk, there's an opportunity for the family to fill it out in the waiting room if they can, which is also great because there's a bit of an anonymity towards that. And they, studies have shown that completing the screen via paper sometimes identifies more cases than not. And having the 2 questions also kind of addressed the literacy issue in that it wasn't too much to read or understand. We also went ahead and had it translated into kind of all of the main languages that the clinic had there, and we put it all on one page so you can choose your language and fill that out. But the next step, as now you can see on this slide, was to give that screen to the medical assistant for them to review the questions. And kind of literacy language-wise, the idea of that was to make sure that the family understood the questions that they were answering, and kind of have another opportunity to discuss that while the MA put it into the computer. So that is how we address that. It's not perfect by any stretch of the imagination, and in fact, a lot of the different clinics, had different patient populations where different languages were a concern, and things certainly did come up. But this was the best way that we found that would have been sustainable to address those concerns.
That's really helpful. Thank you for explaining that. I love that you touched on sort of feeling a little bit more anonymous, and doing it in the waiting room seems to overcome that personal barrier for women, which is really interesting. Is there anything more that you want to touch on related to that? And then I know your workflow here will help us understand if there was a positive score, then obviously the mom doesn't remain anonymous, but it helps them initially feel more comfortable answering honestly. It's just such an interesting dynamic, but I think an important one.
Yeah, and there were a lot of considerations that went into making this process, and also knowing that this process isn't perfect. I will step back and say our ultimate goal was, even if you give a screen and let's say mom is feeling depressed or struggling with anxiety, but she doesn't identify it on the screen, just the idea that this is something that's being addressed and being talked about in the pediatric visit. And we said, regardless of what the score is, you should give information to the Postpartum Resource Center of New York, which is a statewide helpline that New York State has that we thought, could be helpful for anyone. The idea was, if we introduce that and try to destigmatize this at every visit that they come to with their young child, perhaps they'll be more likely to self-identify in the future. So that was step one. As far as the, getting a mom to accurately self-identify, we did go back and forth on that a lot, because some people said, well, yeah, maybe they're filling it out on paper in the waiting room, but the waiting room isn't, it's like a busy, crazy place, and their kids are there running around, like, who knows? So that's why we also said, well, the MA can ask the questions as they put the answers into the electronic medical record to give another opportunity to address it. This was my biggest thing as well. Like, speaking of different levels of staff and how physicians, when they approach screening stuff, it's very physician based. But in my experience, medical assistants and nurses sometimes have really good relationships with the patients that they're seeing, and patients often feel comfortable talking to them about stuff. Mm-hmm. And a lot of these medical assistants and nurses, when we've done these screening initiatives before, they're the most bought into it, because they, see this a lot and are happy to have a way to address it, but they also will say, hey, I went through this issue and I'm glad that we're helping address this, and I hope that moms feel comfortable talking to me about it. So we thought that was another, powerful opportunity. Maybe you feel more comfortable speaking to the nurse or medical assistant than you do to the physician. I've certainly met in our work medical assistants that I'd be a lot more comfortable speaking to than physicians. So the idea is, how can we make all members of staff feel comfortable having this conversation as needed with mom, and therefore provide more opportunities for mom to speak up about her concerns.
That's great. Thank you. And appreciate you teasing that out for us. Great. Well, what happens then once there is a positive score? We see that the doctor will review the score and talk about the patient history and make a referral as needed. Will you walk us through this part? And actually, I'd love for you to just touch on patient history, since we know that sort of larger assessment, mental health assessment, can be important. Maybe you can start there.
Yeah, and I'll actually start by talking about those initial conversations that we had with each clinic leadership about this. It was interesting. We went in making it very clear that we were talking about integrating maternal depression screening into pediatrics. And at first they said they all did that, and then maybe I'll get to that story later, but it turned out that they hadn't been doing that. But then inevitably, about 20 minutes into the conversation, the pediatrician who's sitting there with us would say, wait, you want to do this during the pediatric visit? And we said, yeah, it's an important history for you to know in order to treat the child. And then there would be concerns, well, mom isn't my patient, so what do I do with that? And we said, again, there's steps that we can take, and we'll walk you through that. But also, it's important for kind of like your child's patient history. It's important to that. And then I think, the next concern, and this happens a lot for people who are unfamiliar with mental health services, is the idea that if mom expresses any concerns about her, mental health, that it automatically necessitates, going to a psychiatrist or going to see a therapist, which is sometimes the case, but it's not always the case. And in fact, on the top right-hand corner of this slide, I have this pyramid. This comes from my disaster mental health days. This is from I think it's from the World Health Organization. Now I'm getting things mixed up. But it shows the different levels of intervention and showing that most people will fall in this informal service area. So maybe they could be helped by self-care or kind of informal community care. The next level up would be mental health services through primary health care, or maybe even like, groups or support groups, maybe that are not like therapeutic specifically, but even things like breastfeeding support groups have been shown to address things like social isolation, which we know plays a lot into maternal depression, as well as concerns around breastfeeding, which can be a contributing factor. Then the kind of more traditional mental health services as we know them, so groups or individual therapy that is really kind of focused on psychology or the issue at hand. And then finally, at the very top, psychiatric support, or perhaps kind of more long-term intensive services. And kind of bringing that back to that initial conversation with the doctors, a lot of them immediately said, oh my God, but if they, screen positive on the PHQ-2, then we have to send them to the ER. And so there was first talking through and reminding doctors that all healthcare providers have some kind of emergency process in place. So already, if you were seeing anybody and there was a concern about mental health that was so extreme that you felt you had to call 911, you already have a process in place for that. But let's do some education around this. And let's say that's actually not the case. So we decided, in this case, we used the Edinburgh postnatal depression screen actually after the PHQ-2. So if a PHQ-2 was shown to be positive, then we would give the Edinburgh screen, which is a little bit non-traditional, but just kind of worked for this because it mitigated the fear as well that we would be providing this intensive screen to every patient and it would add so much time, when in fact that wasn't the case. It was only a few patients a month that screened positive on a PHQ-2 that you would then give the Edinburgh. But at that point, the Edinburgh can kind of, has different outcomes. And so for someone who scores kind of low on the Edinburgh screen, certainly talk to them about maternal depression, give them the information, offer them services if they want it, but they may not want, and they may just be okay with that. And then you say, okay, feel free to talk about this with me in the future if you want. Here's the number to call if you'd like to speak to anyone about that. That may be sufficient for now. Those middle scores, increased risk, again, offer a behavioral health referral. At these clinics, they all had behavioral health integrated to their sites, and it was part of their process that they would always refer internally. So we said, all right, then do exactly that and see if mom is interested in meeting with a behavioral health person. And kind of those more intensive, being a little bit more proactive about that. In addition to giving out the information, there's this action plan that we really like from the NIH that they can kind of go through with the patients, making sure that behavioral health meets with them. And in fact, you could ask behavioral health to come up and meet with them while they're still there. But having this referral protocol in place and like an algorithm for what to do set a lot of minds at ease. And for the most part, I think in the entire 2 years that we were screening with this, there weren't that many moms that came up as 10 or more. So it was good for them to have this plan in place, but they didn't have to be as afraid as they were at the beginning.
That's great, thank you. Can you talk just a little bit about, and as you mentioned, it's sort of unusual to give the PHQ-2, which was often used in a range of primary care settings, but then not to follow up with the PHQ-9, instead the Edinburgh. Remind us why you pick the Edinburgh. A lot of people say it's because it detects anxiety, and some people say it's because it does rule about sort of sleep problems, which are common. Any other reasons?
So this was like the great compromise. Initially, when we started this, we came in with a menu of options for how to implement screening, which screens to use, etc. We were a big proponent of using the Edinburgh screen because of the reasons that you said, that it looks at depression and anxiety. But on the flip side of that, for anyone who's familiar with the PHQ-9, we know that it is great to detect depression. However, there's a lot of symptoms on there that could be true of any new mom, such as changes in sleep, changes in appetite, things like changes in behavior, things like that. And in fact, one of the clinics that we worked with, their OB side tried to use the PHQ-9 in the waiting room for all pregnant women. And they had too high of a detection rate that didn't end up panning out to kind of be accurate as far as actual risk for depression. And so we said, hey, like the Edinburgh may be better for this. It may more accurately capture what's going on for pregnant and new moms, and it's also looking at both anxiety and depression. And everyone was on board with that. But then, as I mentioned before, there was the concern, well, this is, 10, I think there's 10 items on the Edinburgh. That's going to be introducing a lot of time in the visit, and with literacy issues, it's going to be too difficult for families to get in, blah, blah, blah. So the compromise that we came up with was using the PHQ-2, which was actually already in the electronic medical record. It just wasn't being utilized during pediatric visits. Why don't we use that? And if a mom identifies positive on those two questions, at that point, you can give the Edinburgh screen. I will say we were doing this project initially both in OB and PEDS. OB was already providing screens, and they were contracted through, I'm forgetting who, but they had to give a PHQ-9 once the PHQ-2 was given. But pediatrics, since they weren't doing this, it wasn't a standard part of their practice, they were not beholden to those same rules. So we decided that we were to try it out. And once we tried it at one site, we mentioned it to the other sites as we sat down with them, and they all thought that it was an interesting idea as well. So that's how we ended up doing it that way.
Great, good. That's helpful. Also on the slide, before we move on to sort of evaluation and sort of lessons learned, can you talk just a little bit about this role of a patient navigator? And I think, those that get their care in community clinics may have this resource more than those who receive care outside of community clinics. But yet we've heard, I think, in several of our Innovation Award winning programs that this has been sort of a critical role in some cases to success. Do you have anything that you want to share regarding the patient navigator role?
Yeah, so patient navigator may be a term that's specific to these federally qualified health centers. The idea is that it's someone who's in charge of managing referrals afterwards. A lot of big hospitals also have some kind of role, so it's anyone who's in charge of referrals. Private practices may also have that, but it may just be the front desk clerk. But then they're the one in charge of referrals. But historically, the patient navigator, at least in the sites that we were working with, really only referred internally to other specialists within the hospital network. We worked with them, and we had a great partnership with each of these sites where they felt comfortable as part of their process referring to their internal behavioral health, but we also created this extensive community resource guide that followed the color coding of this pyramid that's on the top right corner for other potential services that were available to support mom, especially if she was not interested in behavioral health services specifically. And we trained everyone on staff with that, but it was really loomed largest with the patient navigator because, sometimes the physician may speak to the mom about referrals. Mom says, yeah, okay, send them to the patient navigator. Mom sits with the patient navigator, and she says, actually, I don't want behavioral health at all. So it was important that the patient navigator felt comfortable referring elsewhere. But they were a major part of the role because they helped make that link to behavioral health or other resources as needed.
Thank you for explaining that, and it may function a little bit differently in an FQHC than maybe a care coordinator who does lots of things like check the patient's mental health insurance coverage and who's in the network and larger network, those kinds of things. Great. Let's move on then to the next slide, which is evaluation, which is really, besides this sort of deep commitment from a technical assistance perspective, is really sort of another hallmark of your program.
Yeah, so evaluation and ongoing quality improvement was really important to us. We started each kind of site cycle by doing a pre-survey with the staff, where we asked them what their attitudes were towards maternal depression screening, what their current practices were around it, which was always fascinating, because it was interesting to see some folks that said, oh yes, we absolutely have a process in place at this clinic for identifying and referring, when we knew that that wasn't the case. Kind of who they referred to, et cetera. Every month we would sit down and do a chart review. All of these sites use electronic medical records. We were unable to easily run a report of whether or not screens were completed. So instead, we would run a report of all of the eligible visits that month. So in this case, we would run a report of all of the well child visits where the child was between age 0 and 1 year old. Then we would pull charts electronically. If we could, we would go through all of them, but we could also do it randomly, and we would just look in the medical record and see, was a screen completed? If so, what was the outcome? If it wasn't completed, who was involved in the process? Like which medical assistant, which doctor, et cetera. Because that allowed us to try to pinpoint where the areas were. And that's where these plan, do, study, act cycles come in hand. If anyone hasn't heard of it, PDSAs, or sometimes known as PDCAs, they're the same thing, is just this way to conduct rapid cycle improvement. It's pretty self-explanatory. So first you make a plan. So let's say the plan the first month is we are going to integrate the PHQ-2 into every well child visit between the ages of 0 and 1 year when the mom is there. So we do the plan, then we run this report, see how it went, see where the issues were, and then take a next step to address those issues and act on it. So that's a PDSA cycle. So let's say we sat down the first month. There were 10 eligible visits for screens. Only 7 of them were screened. That's still good. There's a 70% screening rate. We want to make sure that we're applauding the staff around that, maybe pointing out the MVP. So if there was one medical assistant that visited all of those families, they were part of that process, we want to point that out. But then on those 3 missing ones, who was involved? Was there one front desk person that checked all of those folks in? If so, we want to make sure that we're checking with them, that they understand their role in this, if there's anything that we could do to help troubleshoot them to make sure that they could, give out the screen, things like that. And then we'd let another month pass as we're checking in, and do another review in a month and do another PDSA cycle. I mentioned before the informal qualitative feedback. So that was something that we were getting ongoing, and we were certainly integrating that into the quality improvement and PDSA cycles. A quick note about billing codes. In New York State, there is a billing code that you could use for maternal depression screens to reimburse. However, what we found, because we had been doing these chart reviews on our own based on these other processes, and at one point we said, oh, hey, can you guys run a billing code report? Because then we could see if that's a good way to use this evaluation, like to make it easier going forward. And what we found was we, like in our own process, tallied more screens being completed than what was showing up in the billing code. So we identified if there was an issue with the billing code generating for all of the necessary visits. And it also showed that at this point, that was not a great it was not a great evaluated tool for this project. So during the project period that we worked with all of these sites, almost 500 screens were administered. There was an average rate of 83% for screening. Of those screens, there was a 7% identification rate. The biggest issue that we came across was, although the screening implementation worked pretty well, and the identification was not too bad, 7%, not bad, not what we would fully expect, but not bad. But a lot of those moms were still refusing referrals. And some that were identified were already in services, but the other moms just were not interested A lot of these moms, again, non-English speaking, immigrant families, I think that there is a lot of stigma, a lot of kind of not understanding the importance of help or really their own well-being for their child's health. So there's still a long way to go there. But as far as the screening ends, it went pretty well. And then we would do a post-survey. We were done working with each of the sites, and we found that a majority of staff were satisfied with the improved screening process. But the biggest ongoing barrier that was indicated was lack of parental understanding, which I think also speaks to that refusal of referral situation that we mentioned.
Yeah, like we know mothers aren't motivated to get care for themselves, but when they understand the impact, potential negative impact on their children, right? That's a motivator. Great. Well, good. I wanted to just touch briefly on your work around ACEs. Really become an emerging issue that a lot of clinicians are starting to hear more about. And I think you've got some great expertise that you might share. So adverse childhood events or experiences. And do you want to tell us a little bit more about your work at Docs for Tots addressing ACEs, but also before we wrap up, how has this been folded into or might be considered for identifying those at risk for maternal depression down the road in this program?
So we know that a mom having maternal depression actually is an adverse childhood experience. So all of this is related. And when we were coming out of this maternal depression screening project, we wanted to look at screening for ACEs in pediatric practices. We were approached by the Center for Youth Wellness, who is a leader in addressing adverse childhood experiences, particularly in pediatric offices. They're based out of San Francisco, and their executive director until recently is Dr. Nadine Burke-Harris. They have had a national learning collaborative around implementing ACEs screening into sites, and we wanted to work with them, and they wanted to work with us because Dr. Tots has a lot of on-the-ground work and kind of experience in practice change in downstate New York. And they had done this learning collaborative with a lot of success that was national. And we said, how can we make this a hybrid and do this focusing on Long Island as the region, but kind of have a hybrid of a learning collaborative and this intensive technical assistance. So this is the first time that Dr. Tots is ever doing a learning collaborative, but we have 4 very diverse health practices in our collaborative. And in addition to having these, like the initial learning sessions and like collaborative calls to learn from each other, we also provide intensive technical assistance. We'll go to their site, do all the things that I mentioned before, and we'll also work with them individually on their evaluation, and then they will bring those learnings to their group and learn from each other. So that's been really exciting. We're a few months into it. We're hoping to expand this in the future. I think that there's a lot of implications, not only for layering this in. One of the sites that's in our learning collaborative is a site that we have done the developmental screening and maternal depression screening at before. So that's pretty exciting that they're also layering this in as another way that they're serving their families. And if it's successful, I think that there's a lot more opportunity to have these broader learning collaboratives that we would be able to reach more practices with a little bit less intensive technical assistance, but still something in order for them to look at these as critical issues.
Great. And more to come around ACEs and predicting and identifying those at risk for maternal mental health, right? I think that is a bit of a cutting edge issue, although it's been talked about for a while. We haven't really seen others adopt that model quite yet. So maybe you will be one of the first, right, Melissa? Thank you. Let's just end by going through some of your lessons learned, Melissa.
So I didn't go into as much of the why our work is so intensive, but suffice it to say that we have found one-off trainings are just not enough. You can't be afraid to repeat things and repeat them and repeat them, because it takes that often for it to actually sink in and to change practice. The best example I could give is before we worked with all of these sites. All these sites for the Maternal Depression Project were affiliated with one another, and we had worked with all of them on our developmental screening project. So their staff had seen how intensively we worked with them. But when we sat down with the head of pediatric quality improvement and we said, hey, we want to look at maternal depression during pediatric visits, she said, okay, we could work on improving that, but we already screen during pediatric visits. And we said, oh, great, that's awesome. And every time we talked to all the different sites, they initially said, oh yeah, no, we already provide that screening. But when we dug deeper, we realized that even though the PHQ2 was available in all of the pediatric visits, no one was actually utilizing it. And the reason that they thought that it was being done was because the pediatric QI provider had given an in-service to all the pediatricians at kind of a staff meeting saying, hey, we put the PHQ2 into the well-child visit electronic medical records, so now you'll do that going forward when you have visits. And everyone said that they would. But that did not happen, because it's very easy, especially if you're at a staff meeting and there's 10 other things that are being addressed and there's all these competing priorities. It's easy to either forget that or to maybe remember it, but when you're in the visit and all these things are happening, it just does not get implemented. So we see time and time again different programs having a one-off trainings and thinking that will be enough for practice change, but we know that that is just not the case, and you need ongoing training, and that there's so many small things that come up that even if there was a little bit of change after one training, it's not enough to make it lasting. We also found that it's important to offer carrots. So in this case, we went through the process of obtaining the right to offer maintenance and certification credits, which are kind of ongoing learning credits that board certified physicians need to have to keep up their license. So the American Board of Pediatrics, the ACOG, even the American Board of Family Medicine, we obtained the right to administer maintenance certifications. So any physician that worked with us was able to kind of have this thing that they otherwise maybe had to pay for to go through a program to get, or something like that. So we made that easy for them. We also wanted to value the medical assistant's time and effort. So we also got the right to administer continuing education credits for any any medical assistant who went through the American, Association of Medical Assistants. We helped them with billing codes to get reimbursement for screening, and we also just provided food. Every time that we had a meeting, did a presentation, wanted to celebrate the success, we brought food. And when you're known as the people who bring food, people like you more. Let's just be honest. Also, can't stress enough the importance of the support staff. It's not just the physician that sees families, it's the entire staff, every kind of part of it. We also know that who asks the question when it comes to maternal depression and how they ask it often makes the difference in detection. And it's important to adequately train physicians to be comfortable having these conversations. But at the end of the day, there are some physicians that moms just may not feel comfortable speaking to. And so making sure that there are other members of the staff who are part of the process who maybe could have more comfortable conversations with mom and kind of know what the next steps are then in that process is really important. We also know that, speaking of it takes a village, practice champions are great. That's all over the literature, that having a practice champion for an initiative is important. However, it can't be enough. You really need to have engagement from the entire team in some capacity, because a practice champion is one person. Sometimes it's seen as it's their project and it's just this other thing that we have to do. And sometimes practice champions leave. Maybe they leave their job or they retire. And what then? It can't just all be pinned on that one person. And then finally, adequate funding and support is necessary. So, we had a full-time person. We were there a lot. And that really was the main element of our success.
Fantastic. We so appreciate your time, Melissa, and want to make sure that our viewers have access to my email, but also especially to yours, should they have questions. We also want to remind folks that the same location that you found this recording on the 2020 Mom website, there are also some resources, including the application that was submitted by Melissa and her team for the Innovation Award program, and there's a lot of great information in that application. So, Melissa, thank you so much for your leadership. We can't wait to continue following what Docs for Tots does in this space and other spaces around ACEs, and hope that we all get to stay in touch. Thank you again for joining us, and congratulations on the award.
Thank you.
Thank you.